Good afternoon, everyone. So this is going to be kind of a different thing that we haven't done before. Um, as you know, I have posted and I will continue to post, especially as we get to the addiction portion. But I posted, so basically what I'm doing right now is I'm giving a lecture for the BSN students as well as my VN students because it's pretty much if you compare I was gonna have them side by side, but then I didn't want to get confused because I want to make this not too long. That way you can stay engaged. And so we're all at the same point. We've gone through depression part one, which is where I drew on the board. Now I am going to do some reiteration of that. It's just not going to be in a drawing. But you can pull that up because you all have it. I know that my BSN students, it wasn't as quite as neat, but you still have it. And basically, I'll fill in the information that you would have needed. And again, it's on here. So I'll mention that and this will all make sense. I have done this many times, but I don't usually save this video because it tends to change. So I did post an anxiety video for both of you guys I'm just gonna say both of you guys, meaning both schools. So that is up. So please, I highly recommend to watch it. The BSN students, I believe, are 1 week ahead of the VNs. So wherever it is, watch it. That'll give you definitely some good foundation, which makes lecture always more, in my opinion, receptive to the students and a little bit maybe easier to understand, especially with I would say anxiety is one of I don't say hardest, but it can be one of the most difficult to kind of sometimes wrap your head around. I love teaching it. It's just a lot. So I kind of have to pick and choose, okay, what's the most important thing? All right, so there's a disclaimer disclosure. Um so very important to watch this video. I know all of you probably have me on high speed, go, go, go to make me go faster. But this lecture is important because I will be mentioning things that will be potentially on your midterm. For example, what I might put on your study guide. And I'm going to actually start right here. So I just kind of started here. I mean, looks very similar. This is the one we used for SJSU. Um, I believe because we had 3-1. Yeah, that's you guys. Because 3-4 was my VNs. Okay. So basically, what we're going to do is start here with Nurse Mike. The only thing I'm going to say about it is on both of your modules, they're both turned on, and I will be putting in your study guide where to watch on there. So of course, I would love you to watch the whole thing, but I'll put watch from here to here. And basically I could just say watch that part about MAOIs, but you know me, I'm a little anal retentive. And if I can save you a couple minutes from having to do that, I will. So I'll be adding that today, and today is Sunday. So um I will put, I can't remember from this time to this time, please watch it. And the biggest thing, I just want to say this. So again, remember when I say that, the biggest thing about this is to know some of the foods that he's talking about. So I don't want you to be stressing and looking through your book. Oh my God, what foods, what foods? So whatever foods he's mentioning, like any foods that are fermented, wine, chocolate, the ones that he's mentioning, those are like foods that you may see on your midterm or future quizzes or whatnot. But definitely because the midterm is the next thing coming up for all of you. And I believe the portion on MAOIs, because MAOIs, I've said it again and I will say it again, 25% of the time on average on your NCLEX, if they're asking a mental health question, it's going to be on MAOIs. Why? Because this is a potentially deadly thing. And we will talk about that when we get to it. But that's why I really like this video, because I like the way he explains it. Also, you guys, on Quizlet, which we will all be going over when we do our review for our midterm. We'll review Quizlet and play Jeopardy, and basically I'm doing the same thing for both classes. It's just one class is 4 hours and one class is 1 hour and 5 minutes. So, all right, let's move down because we've done most or some of this. So we will talk about MAOIs, don't worry. So as I mentioned earlier, if you could get out or if you have that chart next to you that we made. I know it was much neater in the other class for the VNs because we had that big board, and for the SJSU, it had the big board and the small board. But just kind of imagine the wiggly lines, and we had the tricyclics, SSRIs, SNRIs, MAOIs, and then like the outliers. So we're going to get into that, and then we're going to talk just a little bit about things that are extremely important and will definitely be on your midterm. And you guys have all of this. So please, VNs, remember, like for example, they have 4 medications they need to remember. I added Paxil for them. You guys don't need to. You have the 6. Usually it's set off more, but this is why I do it this way. This is the most similar lecture for both classes. So why not? I say pet 2 birds with 1 stone because I don't want to hit them with a rock. We'll start with the first 2. We talked about this in class just a little bit, at least in one of them. I'm not going to, oh yes, no, this I will quiz you on, and you will need to know, very important, that, and for one of you guys, you've already taken it. The other ones are going to take it tomorrow. 90% of our serotonin is in our gut, which means that 10% is where? In your brain. So please keep that in mind, especially for those of you who will be taking your 3-point quiz, my VNs, tomorrow. And I may ask it the other way around, again, not to confuse you, but because it's important to read the question. So I want you to just read it, not just think, oh, she said, oh, 90%. Well, maybe I'm asking it the other way around. So please pay attention to that. And the 2 main neurotransmitters, as we always talk about, are serotonin and norepinephrine. I won't ask you that question. I don't think that's a fair question because there's, especially with this one, there's so many different ones. But the serotonin, knowing that 90% is in the gut, that helps with a connection. So that's why I'm asking, because of the gut health and the brain health, right? And some of that comes up later in this. All right, then we did the board work. So this is basically the board work, and I will be adding on. So for the board work, as we had already spoken about, the tricyclics are not that they're not important, but we don't cover it in either one of the classes. You'll learn that either now if you want, or I would just put it to the side for now and then worry about that before you take your board exam. We still do use them. I know some of this is repetitive, but I want to make sure that everything is very clear. We still do use them, but why do we create new medication? Because we're trying to lower side effects. Some people, I would say, I mean, I don't want to give a percentage, but I would say like 15% of my patients are still on them, but that's just me. That's one person that has seen it. But more patients tend to be now on like the SSRIs, SNRIs, and some other medication that we'll talk about. So basically this is the same for both of you, both of the schools except for Paxil. So for my VNs, I mean, you can know it or not, but, and it should be, I believe, in the same order. So please, it's very important to understand and refer to your whiteboard, or for my SJSU, if you did not see it in the announcements, I did actually write up something because your whiteboard was pretty messy at the end of what is important. So for example, like how it says SNRI, the S, remember, we times it by 2. And this is important for the VNs as well, because we went through this so fast. So I'm going to go through that again. So that's why I said I'm going to kind of reiterate. So SSRI stands for selective serotonin reuptake inhibitor. So what does that mean? It means that selectively, and that's why we talk about neurons or neurotransmitters. So this medication, so there's classifications. So the classification of these medications are antidepressants. They're all antidepressants. Specifically, these 4, and there's many more, are considered SSRIs. So if I were to take, let's say, Lexapro, it is selectively going to my serotonin receptors, and it says it right in the name. So that's what I used to do in nursing schools. I would say the acronym of what the SSRI actually means, and that would help me remember, oh, this is what it's doing. So it's selectively going to serotonin, reuptake inhibitor. So we're inhibiting the Lexapro from being recycled. So one question that I ask, and I asked this in lecture, if you did not recall, which is when we're taking these medications, are we creating more serotonin or are we utilizing the serotonin we have to its optimal level? That's exactly what we're doing. So we're utilizing the serotonin we already have. We're not creating more serotonin. So what are we doing? We're causing, or we're hopefully, and remember, of course, not all medication is going to work for everything or for everybody. But what we're doing is hoping that, let's say again, I'm taking Lexapro, that I am inhibiting the reuptake of Lexapro and inhibiting it from what? Remember, we talked about that gap, the synaptic cleft, synapse, whatever you want to call it. I don't ask the question, but it's important to understand what's going on in the brain. But I won't actually ask that question because that's kind of a juvenile or like under question, if you will. We're at a higher level of thinking. But also, in order to help understand what is actually going on in the brain, I think it's important if you can memorize what this is, it's going to help you understand how the medications work better. So, my hope is that I'm helping to not reuptake my Lexapro, and the longer that it's going to stay, the Lexapro stays in that synapse, the more, hopefully, if it's working for me, the more that I'm going to feel the effects of the medication. And I did not say this in class, but I'm going to give a quick example. Remember, this is a lecture, so it may go 45 minutes, but it's going to help. So if Lexapro, if it stays longer, and I think I shared with one of the classes, I had been on Lexapro at one time during a rough time in my life. Okay, not ashamed of that, no problem. Went on Lexapro, and it worked very well for me. And so that to me is indicating that that the Lexapro is staying within that synapse for a longer period of time. Therefore, I'm getting the effects from it. And many people will ask this. What am I supposed to feel? A lot of my patients will ask me, well, what am I supposed to feel? So I know in class we say well-being, and that's just to help spark the idea. I don't expect you to use that and say that to all of your patients, because what does that mean? That's more for you. But really, what I usually will kind of bounce back to the patient is I had already gotten their assessment, right? And again, I can't ask a question like this. So number one, I will never ask you about the well-being thing. That's just for you. And the example is to help with the connection. So let's say my patient came in and said that they're very, feeling very lethargic. They have lack of appetite and they just don't feel like they want to do anything. They're not getting pleasure from anything that they would normally get pleasure from. Like they used to love to play golf and, be out in nature. So usually I use that, their symptoms, and will let them know if the medication is working, because we don't want to give false hope. And that's why I mentioned euphoria. A lot of people think serotonin is for euphoria. It is not. Dopamine, not dopamine that you get for like when you're there's different types of dopamine for different reasons. I'm talking about like drugs dopamine. Dopamine is what can potentially cause you to feel like that euphoria. Serotonin, that's why I like the word well-being. So I don't want my patients to think, oh, you're going to take Lexapro and now you're going to feel like you're going to run an 8-mile marathon in 2 weeks and you're going to feel great. And oh my God, life is going to be glittery and gold. That's false hope. It can work. I will say it again, everything's on a spectrum. And my usual answer will be, well, it works different for everybody. And this is an important part, and we will talk about it when we get to it, but how long it takes to work. So we have to pick a number. And that's something that goes with patient teaching. So somewhere you'll read it 2 to 4 weeks. Some you'll read 2 to 6 weeks. Some you'll read 3 to 6 weeks. I have to pick a number, right? We have to pick a number for here. On your NCLEX, they're going to give like such a large amount of variety between the numbers that you're not going to, just like I would. So for us, it's 3 to 6 weeks for an antidepressant to start taking effect. Now, can it start working sooner? Yes, it can. Once we hit 6 weeks, we really want to start taking a look at that. And even during that time, we can start to titrate it up as the care provider may want to. All of this you don't need to know for a quiz or a test, but it's important to understand. What you do need to know is the 3 to 6 weeks. Your book may say one thing, and again, may say 2 to 4 weeks. We are using 3 to 6 weeks, again, because we have to choose a number, and it's on here, and we'll get to it. Let me just show you. So right here, 3 to 6 weeks for antidepressants to take effect. So if you're in a pharmacology class and they say 2 to 6 or 2 to 4 or 3 to 4, that's not wrong, but I have to choose something because I'm going to test you on it. So we're going to say that. So first of all, I'm going to let my patient know that, and then I'm going to put back their symptoms onto them and say, okay, well, I've noticed here that you have not been feeling pleasure doing things that you normally like to do. I know you like to golf. I know that you, and correct me if I'm wrong, that you're not having as much appetite. What you might notice is a little bit of kind of like a shift in that. And that's what we should feel, because the whole point of putting you on this medication is to help with those symptoms. So that's why we'll have you check back in with the psychiatrist or whomever, prescribed it. And they'll usually have them come back. I mean, in my personal opinion, should be pretty soon, in like a week or two. Some do a month because it, like I said, can take 3 to 6 weeks, but and then let them know to contact the office, of course, if something is not going right, or they're not feeling well on the medication. So point being is 3 to 6 weeks. I like to say well-being for SSRIs. And we need to understand that if we see Prozac, Paxil, Lexapro, and Zoloft, that those are specifically SSRIs. That is important, because then you're able to know which receptor, and not for my VNs, just erase Paxil out of your brain unless you don't want to, because then we know exactly how they're working. Now we go underneath. You all have these 3. The SNRIs. And how I mentioned this also is that we double use the S. So even though I feel, why don't we just put another S? They don't. I've asked many, many people, as well as pharmacists, and I cannot get a clear answer, but it is what it is. So we double use the S, because we're also selectively, if we didn't selectively go, then we wouldn't get to these neurons, right? Or neurotransmitters. So we have a selective serotonin, norepinephrine, reuptake inhibitor. Again, if you're looking at your board work, you'll see that. So we're double using the S for selective and serotonin. N stands for norepinephrine, and that means that we're working on 2 different neurotransmitters. Serotonin, so inside of that synaptic gap, we're hoping that we're, again, if the medication is working properly. And when I say properly, I mean, because as we all know, medications, 50% of the time, it's 60%, whatever, an antibiotic isn't even going to work. And we have to do another one. Who knows? So we don't know which medication is exactly going to work for you, but we're hoping. So, this could easily, again, I say it could be a 9-hour lecture. So we're shrinking it down. So let's say I'm taking Effexor, and I know, so for all of these meds, again, all these SNRIs, they are classified as antidepressants. Specifically, they're SNRIs, which means they're going to selectively go to serotonin and selectively go to norepinephrine. When they go to serotonin, we just say it to help bring it to memory, creates well-being. Norepinephrine, remember, it's 2, and we go in alphabetical order: energy and motivation. And what are we hoping? That it is not reuptaken too quickly, so that it's in the synapse. Therefore, the longer it's in the synapse, the medication's working. And then it's just going to be kind of working like I don't know, I can't think of a word. It's going to be working like a nice, smooth conveyor belt. I don't know what word to use there. But so they basically are doing the same thing, except we have an extra neurotransmitter here, which is norepinephrine. Many people ask, well, how do they choose? And there's so many more medications, and we're hitting each of the real true classifications. Tricyclics, we've already kind of talked to, like, okay, you'll learn about them later. SSRIs, SNRIs, MAOIs, and I'm going to say right now, MAOIs, I've told you, I think, I don't know if I told both classes, I've only seen one ever prescribed in my entire career of 14 years, just one. Not that they're a bad medication, but based off the homework and when you're going to watch Nurse Mike's video, there are so many contraindications. It's like, I don't know, people are just scared to use them, or it's just it can be a problem, and we want to try to avoid that. But sometimes we have very medication resistant patients, or they just happen to be on one, and yay, it works. So I will never ever quiz you on a name of it. I just want you to understand them, which I will talk more when we get down to those. Okay, so this is kind of reiteration of the board as well. And then just so you know, we're doing a reiteration of the board, then we're going to talk about this. This does not take as long as it looks like it's going to take, just as an FYI. Okay, some very important things to, actually, I'm going to do this in order. The board work first. So we went through tricyclics, SRIs, SNRIs. The next one was MAOIs on the board. So the number one thing I need you to remember is no tyramine. And that's where it comes with all the foods. And Nurse Mike will explain it more, as well as your Quizlet card when you flip it over. So it's the tyramine that becomes the big issue. These foods have tyramine, and the medication in itself, when mixed with most things, will create tyramine. It's basically tyramine is the issue. And what it can do, and there's other reasons why, but this is the main one because this can cause, remember, this medication can potentially, I mean, all of them can cause death potentially, but this is like the big one that we really want to really remember. No tyramine, what types of foods, and again, that will be in Nurse Mike's video. And it's because the tyramine in your body can cause a hypertensive crisis, which is not good because that means that blood pressure is going to shoot through the roof. And that can cause not just, I mean, not good things over time, but also it can cause a stroke. So that's really what we want to pay attention to is tyramine, and why? Because of hypertensive crisis. So please read the questions carefully. I might put hypotensive crisis, something else, something else. So please read the questions. And then also, I'll put this on the study guide, but I want some examples. You need to know certain fermented foods, and it's going to be all taken from Nurse Mike's video because I want it to be easy to find, and because I want you to remember. Again, I'm not trying to confuse you. I want you to remember. Okay. Then the next one's going down, and then we'll come back up because we're doing part one still, was the off-label and kind of the outliers. So we have this medication. Actually, let's talk about trazodone last. And probably a lot of you recognize this one. So we have what I call an outlier, and it's called Wellbutrin, also called bupropion. And this medication specifically goes to norepinephrine only. So this could be, and I actually kind of skipped over, I was going to say, a lot of people ask me, well, how do providers choose what medications they're going to give? And I made a joke in the VN class about like the drug reps come in and they feed you and they wear sexy clothes or whatever, just to be funny. But truly, a lot of practitioners, myself included, not able to prescribe yet, but I have medications that I feel more comfortable with. And there's really no right answer. I mean, you'd have to talk to that actual practitioner. Hopefully they're asking a lot of questions and trying to, because imagine this, the more medications that we have to try, you're already not feeling good. You feel depressed. This one's not working. Now I have to do this one. Now I'm having side effects from that one. It just, the best that we can do to try to get it the first time or the second time or whatever we can do, the better. Again, I'm not going to quiz you on that, but this is about patient care, right? Okay, so now let's go to the outliers. Now you have your chart. It says outliers on there. So again, Wellbutrin. I love the name, Wellbutrin. So Wellbutrin has a couple things that I'd like you to take note of. So the classification of Wellbutrin is an antidepressant. And we're going to talk about this later, so I'm not going to really bring it up now. But antidepressants can also be used for general anxiety. That's somewhere on here, I think. You will learn that later. but I just want to mention it now. Not panic attacks, not anxiety attacks, not anxiety in the moment, but for general anxiety. And they're often prescribed for that. And that's not considered off label. So I just want to say that. Now, we know that Wellbutrin, so you'll also need to know that these medications as well, what neurotransmitter they go to. Okay. So, like the ones up here, and we know what neurotransmitters they go to, it's the same thing. So if I say what classification is Wellbutrin, is an antidepressant. If I say what is the classification of Remeron, it's an antidepressant. So, and these ones aren't specific, like the SSRIs, SNRIs, they don't have that specifically. They don't have that any acronyms to them. So what Wellbutrin does is it goes straight to norepinephrine, and we know what norepinephrine does. It helps with energy and motivation. Well, why not just give Wellbutrin? It all depends on the patient. Maybe some patients don't do well with medications that touch the serotonin neurotransmitters. So this is something, that is an option. And it can also be used off label for, and I will put this if I'm going to quiz you on it, but just keep in mind that it can be also used off label because you will see this for smoking cessation and ADHD as well. So on label, it's an anti-anxiety. Oh, sorry, my apologies, an antidepressant, and can be used off label for smoking cessation. If you don't know what that means, it means to help not smoke. Helps with the cravings, and it can also help with ADHD. Okay. Again, I will put things on the study guide that you need to know. All right, now we're almost to the last part. We have 2 more medications that you need to know, and this is the last part of depression, part 1. Then we'll do part 2. Part 2, I would say, is easier because it more has to do with kind of I don't want to say holistic, but just some other things to kind of look at, and I have some other things up here that are yellow, so I'll make sure to go over, make sure I don't miss anything. But okay, so one of the last medications, and then we'll talk about trazodone, is Remeron. We don't see this one quite as much. It's also called, and I can't say it quite right, so don't make fun of me, mirtazapine. That's what most people know it as. And this one utilizes serotonin and norepinephrine. I don't normally quiz on this one, but if I do, I will give some indication on it. And the thing about this one is it's what I call like a 3 home runner here. It can really, really help with certain things. And I personally am very careful with this medication as a nurse seeing it, and I'll tell you why. So the hope is always, my hope is less is best. If I can give you a medication that's going to help. So if I have someone come in that says that they're having general anxiety and depression, I'm going to definitely go for usually an SSRI or an SNRI because I find those to be most helpful with that specific. Remember I just said general anxiety antidepressants can help with that. Again, you don't have to remember that. I'm just giving you an example. Well, this one here, the Remeron, is an antidepressant. It says it right here. Also, it helps with insomnia, so you take it at nighttime, but it also helps with appetite. Well, that's important because if I have a patient, and this is, I felt so terrible for, I had a client, I'm not going to say where, when, how, what, and all of that, but when they came into treatment, I believe gained maybe 30 pounds and and I'm not trying to say that this is a bad medication. It's not a bad medication. But she gained, it was like 15 or 30 pounds in 2 to 3 weeks. And that's not healthy. We don't want that. So why are we choosing this medication for this patient? She was already a little bit over BMI. And people do tend to eat more in general. This was at an addiction facility, especially, well, that's all I'm going to say, with the substance that she had come in on. And so to me, that was a horrible choice to make. Now, if I had a frail patient come in who was underweight, having trouble sleeping, and depressed, oh my goodness, I could not ask for anything better. Here we go, right here. but I'm going to watch that that weight because it does help with appetite, and then I may need to change it at some point. So, very interesting medication, can be utilized. That's why I talk about, like, why I love medication so much, because if you understand it, you can really, really help people, and not just with medication, with other things, and that's what we're gonna go to in just a minute. Y Okay, so Remeron can help with depression, insomnia, and appetite. Now the last one, Trazodone, and I know that seems like a lot of medications, and I don't want anyone freaking out, like, "What do I need to know?" I will let you know in your study guide, okay? So trazodone is used off-label. So trazodone is a medication back in the day was actually made for depression. So technically, so if I asked you right now, I wouldn't ask you on a test because again, it seems juvenile to me, but I want you to know it's classified as an antidepressant, but it's used off-label for sleep. I have never in my 14 years seen trazodone used as an antidepressant. And that is because in order for serotonin to even be it's basically an SSRI, it goes to serotonin. Um, for serotonin to even be utilized or touched, it takes 400 to 600 milligrams. So that's the other thing to think about too. All medications have a certain dose because not only does if you're taking orally, your liver's breaking it down and it's going to break it down even more. We have to think about that as well. I'm not going to test you on it, but this medication gets broken down quite a bit. So they noticed when they were prescribing it at that level of 400 to 600 milligrams a day, it was working, but patients were just sleeping all day. So yeah, I'm not depressed, but that's no way to have a quality of life either. And so some genius thought, well, this is a non-addictive medication, and I will explain what that means when we get to our addiction portion. There's a certain specific place in the brain it needs to go to in order to be classified as that. Not that something can't be used and be dependent on. We'll get into that. That's kind of a little bit of a controversy, but we'll talk about it to hopefully make it make sense. So when I say that, if that kind of gets you like a little bit feeling weird in your visceral areas, I will explain what I mean by that. So then they decided, and this is actually, I would say, one of our first line prescription medications in the addiction world for sleep. Because, and remember, please, you do not need to remember milligrams, but I would say usually 50 to about 150 milligrams, either PRN, so it could be as needed. However, the prescriber prescribes it. It's usually PRN, and people tend to take it every night. And in my opinion, it's a good medication. I get very, very few complaints about it. Some people don't have that same, opinion, and that of course, that's okay. I'm just talking from my opinion. Insurance covers it, and it works great. So now, does that mean that this medication cannot be used for antidepressant? No, and I will not ask you that question and try to confuse you either. I'm just explaining that why we normally do not use it as an antidepressant. And the last thing I'll say about this is I'll hear sometimes people who are not really trained or should not be doing patient teaching about medication say, "Oh, good, I see you're on trazodone." And I'm not going to mention what type of employees because I don't want to put any type of healthcare individual down. And I'm talking anywhere from social worker to therapist to whomever. "Oh, I see you're on trazodone. That's great. That's going to help with your sleep and your depression." No, it's not. They're on 100 milligrams. That's not even touching your, serotonin receptor. So, okay. So with medications, I feel like we've done a good job. You can't see it, but I'm going to pause it real quick because I need to let my dogs out to go to the bathroom, and then I'll be back. And we're going to do part two, which is basically things to consider. So part one is done. So now basically the board work has now been filled in, and that's done. And if you're feeling a little overwhelmed, remember, study guide, study guide. I will point you in the right direction, okay? And we will go over this again, and all of this is on your Quizlet, which we will be doing also the Jeopardy, so that we have reiteration. Not just to get a good grade, because I want you to remember this stuff. I mean, we'll still be going over this at the end of the semester, because I want you to remember. Okay, so I'm just gonna pause it. You won't know it, but I'll be back. Okay, now resuming, we're gonna go to part 2 here, and that has to do with things to consider. I just wanna make sure before I do that, that I did not miss anything up here. Nope, was perfect. Okay, so things to consider, definitely important. So I would know this. It's not highlighted, but this is something that I ask from just memory and recollection, because this is usually how it's going to be documented in the chart is MDD is major depressive disorder. So please make sure that you understand what that stands for. So MDD is major depressive disorder. That is taken from the DSM-5. And remember, you must, of course, qualify for that in the book, right? So I can't just diagnose anybody with major depressive disorder or anxiety or whatnot. General anxiety, panic disorder, it must be from the DSM. I do put down here circumstances. This is just to kind of get us thinking about, and I don't mean to trigger anybody, but there is a difference between this is just what I call it, having a chemical imbalance and having a circumstance. Now, that doesn't mean that the medication won't help with circumstances, and I will not test you on this. I'm just, again, putting things into context and trying to make connections. But for example, and I can't believe I'm giving this as an example, I have my dog sitting next to me right now who refused to go back in the bathroom while I record. She wanted to be a part of it. If something were to happen to her, I would literally probably miss work for 2 weeks. I don't think I'd get out of bed. I probably wouldn't eat. I would probably have somatic symptoms, and it would be absolutely awful. I may go on other medications to help with anxiety and whatnot, like panic attacks, maybe, all of that. But that doesn't necessarily mean that I have a chemical imbalance. Something happened that was tragic in my life. So I'm just gonna leave it at that, and just kind of understanding that these two things are different, basically. Again, it's not going to be quizzed or tested on, and I think everybody, if you have questions, please let me know, but I think that makes sense. At least it does to myself. And there's so many different examples I can give in so many situations. That's what makes this a little bit difficult, because I mean, what if this continued lingering on and then something else happened? Let's say then your you and your spouse split up, and then on top of that something else happens. I mean, so that's what I mean. Circumstances and circumstantial can lead to definitely this as well. Okay, so I just wanted to say that out loud. You need to know this. Not everything is going to be a diagnosis. There may be circumstances of why you're feeling a certain way, and maybe temporary medication may be used to help kind of cope. And when you can cope, and I mentioned this before, it's really hard to go. It would be like me not feeding you for 2 days and then asking you to take or write a 5-page paper, right? It's kind of the same thing. If you're feeling very sad or very anxious, it's going to be very difficult to be able to concentrate, to be able to go to therapy, to be able to do any coping skills. So now we're getting into that kind of stuff. So therapy, a few examples, and I do not quiz if I do, I'll put it there, but if I ever did, it would just be the acronyms, just for you to understand that there's different types of therapy, but I usually don't. But just please note that there's even more than this: talk therapy, cognitive behavioral therapy, dialectical behavioral therapy. And the reason why I like you to know this is because some people are not as familiar with therapy. And I want you to make the connection that therapy usually isn't just going in and just complaining, and a therapist then gives you advice. That's actually not what it is at all. Usually what the therapist does is guide you along the way, and then we'll ask you questions to help yourself kind of come up with something. And it depends what kind of therapy it is. For example, DBT. DBT is dialectical behavioral therapy. It's actually one of the therapies that we use mainly in addiction now because it's been proven to be very, very helpful. And just as a quick example, what DBT does is it really helps with skills in the moment. So if I'm having a craving, or actually this one, because I will use this with you guys if you're freaking out or having some feelings of despair or whatnot, and you come up and ask me like, I don't know what I'm gonna do, or ch- checking the facts. So checking the facts is actually one of the skills of DBT. It's one of my favorites for me. So this is a skill I use a lot. So I check the facts. So for example, today. So yesterday I was sick. I was not feeling well, and I had trouble sleeping because I knew that I had not gotten as much done today or yesterday as I'd wanted to, and didn't want to get behind on my own schoolwork or this type of work. But I checked the facts and said, okay, you have all day. You have nothing else that you need to do outside of the home. You will get this done. And if you sleep, then you're going to have the energy to get it done. So for me, and of course I did some more, I'm not going to tell you the whole life story there, but for me, that really helps. Or if let's say I took a quiz and I got an 18 out of 20, and you know how we're all hard on ourselves. Okay, so I missed two. I'm about to take a quiz actually after this, that I don't feel fully prepared for. I have a 97% in the class. So if I miss three, okay, so what if my grade drops to a 95? For that moment, that's okay. I'm checking the facts. So just wanted to mention that. So therapy can be very, very, very helpful. But again, just remembering that if you're going to go to therapy and you believe in therapy and truly, as a nurse, and I've mentioned this many times, I think that all healthcare providers should be offered free therapy at the place of their work. You don't have to do it. Not everyone believes in it. I'm not here to change your mind about anything, but it can be very helpful to help place what we see on a day-to-day basis and not burn out. And it can be really hard, especially for those of us who are like, I'm super mushy gushy, but I've learned, boundaries and whatnot, but I'm still human, and I am mushy gushy, and I feel things. I cry. It, you know, it's okay. That is okay, but it's when, how, where, and how you handle it. Okay, alternative therapies. So there's alternative therapies. I do not quiz my BNs on this. My BSNs, I will probably later, and I will put it in the that thing in the study guide. So it probably, well, I can pretty much tell you it's not going to be on this midterm, but it'll be on your final. I have videos up, and I will put it, say to watch them, and I will, give you examples and whatnot. So please don't, I'm hoping you're not stressing over this. There's also ketamine as well, because I want you to understand, I didn't put ketamine here. Alternative therapy. So TMS is transcranial magnetic stimulation. We're going to put this to the side because it's not what we're going to be talking about right now. It's going to be later in the semester. And ECT. So I think a lot of us are familiar with this one, the electrical convulsant therapy, where we basically put someone into a seizure. And then ketamine therapy, which is more of the newer kind of thing where we're using ketamine to help with depression. So I will be posting the videos. They are there. I just haven't published them yet because we're putting this to the side for now. So VNs, I'll still post the videos for you, but you're not responsible to do this on a quiz or a test. But I still think it's super interesting, so I would still watch it. Okay, so this comes later. Just kind of ignore it for now, please. Okay, very important. What does that mean? Very important. First of all, we're going to start with this. What if someone is having SI or HI? This is important. This you will see, all of you who are listening to this. So if somebody tells you, so first of all, okay, how am I going to ask? How I like to ask, I'm not going to quiz you on this because it's not just one way. I like to put it into one sentence, number one, because I just feel it's more comfortable. It's more comfortable for me. And if I'm more comfortable asking this way, it's going to come off more comfortable to my client, right? So usually if I'm asking about this question, I'll ask my client, are you having any feelings of hurting yourself or others or anyone else? And it's all in, one bulk, and then we go from there. Now, if they say yes, what do you say next? Boom, right here. You will see this, all of you. Ask if they have a plan. That's it. We're going to stop there. Of course, if you're at clinical, You come tell me. But for the test, you need to know what is the very next question. If someone is having suicidal ideation or homicidal ideation, do you have a plan? And we're not going to jump right out of our seats and run away. We're going to just continue talking. And it's a little bit out of our scope, especially if you're like brand new. You don't need to dig, just continue talking until there's a good place to stop with the conversation, and then you'll go tell someone. But this is really what you need to know is, do you have a plan? Okay. Understanding what a wellness and a welfare check is. Not sure if I'll quiz it or test you on this. If I'll put it on the study guide. All right. Understand welfare check / wellness check. What that means is basically you're worried about somebody because you're talking on the phone and they just say, I'm just feeling so hopeless, and I have this bottle of Tylenol. I think I might just take it. So what I do, and I've done this many, many times, and many times actually with my students as well, I call a welfare check. So I call the non-emergency for police, and the police will go out and do a welfare check to make sure that that individual, they'll do an assessment. I have my own feelings about that, so I'm not going to say that here. Okay, yes, I am. I feel that they should have a social worker or a therapist with them or on the team, something. Not that I'm not saying anything negative about the police or police force or anything like that, but I just feel that maybe we would get some better results because I've seen a lot. Let's just put it that way. And maybe I'll tell you some stories in person. I don't want to have that on this recording. Okay, so again, if I want you to, please, kind of keep this in your mind, but if it's going to be on a test or anything like that, it's going to be on the study guide. Now, I mentioned this before. This is very important. And I probably won't ask you this until we get to anxiety, but just in case, it is common, not always, but we commonly see general anxiety and depression diagnosed together. So let's say on a quiz, I ask you, or it's not going to be on the midterm, I'm almost positive. This will be like on the next quiz on anxiety. So if I said true or false, depression and panic attacks are often diagnosed together. No. True or false? Are general anxiety and depression often diagnosed together? Yes. It's general anxiety. Why? Let's make that connection. What did I mention earlier? Anti-anxiety, or my apologies, antidepressants can also be used to help with what? General anxiety. So that means if I'm having a panic attack, I can't just take a Prozac in that moment. It's going to work like that. And more of this will make sense. Like I had mentioned in the very beginning, it all builds. What medications help in that moment. So general anxiety, that's the key point there. Okay. And that's kind of when you just have that underlying anxiety, and sometimes it goes up a little bit and sometimes it kind of mellows out, but it's just kind of that general anxiety where it lays underneath. If you have any questions about that, let me know. Something just to keep in mind, and I think I've mentioned this is, and by the way, we are getting to the summary. I know this is long, you guys, but I have to make sure that you have this under your belt. Otherwise, it's not fair, and it's very important. And a lot of this comes together so well. And remember, we will review it on Quizlet, so not everything is here. Everything is here, but it's also on Quizlet. So relapses can take place, and if you haven't watched it yet, and we will watch it for this Friday for SJSU. Call me crazy. Don't watch it if you haven't seen it. And then for my clinical students, they always watch it before we go to clinical, because it can definitely help with seeing what type of patients we see where we go to clinical for Mission College. So relapses can definitely take place. I do believe that when we hear that word relapse, we think of drugs and alcohol, but relapse can take place for mental health in general. So somebody can be diagnosed with MDD. That is a diagnosis. And then for 3 years, everything is, pretty relatively normal, if you will, normal, quote unquote. And then all of a sudden, and you'll see in the movie, if you haven't watched it, Eddie, he goes through relapse, and then he gets put on a 5150, goes back into the hospital, and they titrate medication, do therapy, whatever it is that he needs at that time. But that can happen. And it's not only because people stop taking their medication. I do want to mention that. It can happen because the medication, it's like, it's kind of a funny example. I don't think I've ever used it, but like shampoo. If you've ever noticed, sometimes you've been using the same shampoo for so long, and then all of a sudden you're like, it's not really working the way it used to. No, that's kind of a funny example, but it can be the same for medications for any mental health diagnoses. Okay, so let's see here. Where's the cold turkey one? Where it talks about, because that's really important. We never want to stop taking our that's why I thought something was up here that was important. We never want to stop taking our antidepressants. Really, just in general, when I think about it, any anti or medication for mental health, just keep it in your head. We never just want to stop it. Even though some of them we can, I just keep that in mind because there can be huge complications. So, for example, I'm trying to find it right here. Here we go. So, why do we not stop antidepressants cold turkey, meaning we just stop them? So let's say you're on Lexapro, and we're not going to play these games of, oh, that sounded rude, but like, what if I was only on it for 2 days? Okay, that's different. We're just going to say if you've been consistently taking an antidepressant and you just stop it, number one, it will cause you not to feel well, because anything that touches serotonin, and I'm just going to use serotonin mainly, you're usually going to feel like flu-like symptoms, especially with the SNRIs, that norepinephrine, you get these sharp, like shocking pains in your head. So it's not pleasant. We want you to titrate down on the medication. Another huge thing is this, and this is what you're going to be asked about. It can cause SI. So it can actually cause, so if you just abruptly stop your antidepressant, it can cause rebound suicidal ideation. Just like when you're taking an antihypertensive, if you just stop taking it, it can actually cause rebound hypertension. Read your questions closely because I might put that as an answer, and read it closely. You do not get rebound hypertension from stopping your antidepressant. You get rebound SI, or potentially. So that's why we do that. Another warning is also, and I don't see it on here, but it's important to know, in the beginning of when you're taking an antidepressant, and just write this down on your notes somewhere. I don't even know if I'll quiz you on it, but I still want you to be very aware of this. Why we like to keep an eye, and this is why I like my patients to come back, or I'll call them in the first couple days. Or just when you start an antidepressant, it can actually cause you to feel suicidal. I know that seems odd, but it can. And that's usually when people, unfortunately, will live out their plan of taking their own life. Because for that time where they're so depressed, they don't have the energy. But now all of a sudden I'm being put on Cymbalta, which is an SNRI, or Prozac, which is an SRI, or Wellbutrin, which only goes to norepinephrine. But now it's giving me some energy. And now I'm able to, carry out that plan because I have finally the energy or motivation to do it. I don't usually quiz on that, but I want you to know that and remember it. So please write that down. I always ask about this one though, about not stopping cold turkey. But that's usually why your care provider will call you or ask you to come back in a week. It's not because they're just trying to get money out of you. It's because we want to make sure that you're okay and you're doing okay on the medications, and we want to see your face and your body language and all of that. This one we already talked about, and I will put on the study guide which part to watch. We've already talked about this. It takes on average 3 to 6 weeks for antidepressants to take effect. Then we start, increasing the dose, and then we may need to change the medication. We may add in another medication. Okay, great. But what do we need to be careful for? I'm going to go down there right now. What we need to be careful for is something called serotonin syndrome. I know it says MAOI right here, but that's because a lot of the times this is what happens when people are on MAOIs. And are put with another, and actually, I don't want to get too much into it because I don't want to confuse anybody, but just be attentive to the fact that serotonin syndrome can happen. This is also on your Quizlet. So, for example, let me give you an example. If yes, there are people that are on more than one medication for depression or anxiety that have serotonin in it, and they do just fine. There's some people that can't take serotonin at all because they're so sensitive, and they will get serotonin syndrome. Quizlet has more information on the signs and symptoms. Again, I'm trying to get through this, and I know it's taking a little bit longer than I originally said, but I want the information here for you. And I want you to get, hopefully, out of this everything. And remember, we're going to go over it again. We always go over everything twice. So, for example, if I'm doing a medication reconciliation, and if I have a patient that's on two, I'll usually ask them, oh, I see that you're taking Prozac, and I also see that you're taking Cymbalta. How long have you been taking these medications together? Or something like that. I will not quiz you on this. And just to get an idea that they're not having an, are you noticing any symptom? Or actually, normally that's not how I ask, because then patients tend to get worried. I would usually ask, how are your medications going? Or have you noticed any issues or anything that you'd like me to bring up to your care provider? Because, as nurses, we'll be the first ones to usually see the patient, depending on the type of atmosphere and where you're working. And then I'll go from what they're saying. But we are careful, and the care provider should be careful on providing a medication with too much serotonin, and that's why we have, max daily doses and whatnot. So then we come to something, okay, I have a patient come in, I'm doing a reconciliation of medications. If you don't know what that means I've asked a patient to bring in all their medications. It's usually on the first visit. So I can go through them and I say, please bring in anything over the counter, any supplements, any powders, bring me everything. And I see this medication here. This is also often asked on your board exam. So you will see this, I promise. I think I spelled it wrong, but you will see this on a quiz exam somewhere, probably your midterm. And then again, because remember, I want to put the ones that I think you're going to see as much as possible, or the ones that can cause pretty bad damage and or death. So St. John's wort, I would never name a medication that, but that's just me. Doesn't sound appealing. It is an over-the-counter medication. So this can happen. I think a lot of individuals, not all, but think, oh, over-the-counter, no big deal. It can't be risky, can it? Well, yeah, because Tylenol is one of the things, unfortunately, people tend to use to overdose because it will put someone into liver failure very easily. 4,000 milligrams is the max daily dose a day. So, of course, I'm not going to tell my patients that unless I need to for a certain reason, but especially if they're coming in already suicidal and they're not being kept on a hold. So St. John's wort is an over-the-counter supplement because not everybody wants to take a medication. And these are things that I suggest too. Not a problem. And when I'm allowed to at work. And a patient will ask, well, how does it work? And basically what it does, and I won't actually ask you, or I won't explain it in this exact way, but it basically activates the precursor for serotonin. And that precursor is called 5-HTP. So I would never quiz it like this, but I would ask in some way, which of the following over-the-counter medicate or supplements could potentially be harmful if somebody is taking an SSRI due to it causing serotonin syndrome? And it would be St. John's wort. I would ask the question in that type of manner or similar to that. So again, St. John's wort, it's over the counter. It activates 5-HTP. I will not ask that in that specific way. But that 5-HTP is what is the precursor to serotonin. And because of that, it being a precursor, it can actually have an effect if you're already taking, let's say, Prozac at 80 milligrams, which is the max daily dose. And then I add in this, you can get serotonin syndrome, which can be dangerous. You can check that out on the Quizlet site or thing. Okay, so we're summing it up here. I know it's a lot of information, but I hope that it's been helpful that I've been saying, remember this is important. These are examples of how I'd ask the question and whatnot. Serotonin syndrome can be a big thing with MAOIs. That's why I put it there. I'm not going to ask you that. I just put it on there. And then under resources right here, I will eventually, like I said, be publishing it, but it won't be till later in the semester. ECT, TMS, and ketamine. This will be important for my BSNs. And then my VNs, please. I would love if you would watch them. I did put the links here for you too, if you'd like to watch them. And then, of course, there's other things that we can do: acupuncture, meditation, exercise, many other things. Last thing I'm going to say here is we always say this, eat well, exercise. When you're not feeling good and you're depressed, and every single person I'm sure listening to this has had one of those days where you feel just like, oh, I don't want to do anything. Imagine that times whatever, and you're depressed, like you have MDD, and it's not easy to get up and eat a meal, or even if someone brings you the meal, the motivation is not there. It's just, you feel so, just like the oxygen has been sucked out of you, basically. So sometimes the medication can actually be the beginning. It doesn't have to be forever. A lot of people ask me that too. It does not, and my patients, I'll tell them too, it depends on many factors. And if being on the medication is not your goal, I absolutely will work with you and we'll see how things go. But if we can get this in your system, get things going, and then start some other things, such as meditation, because you're going to see all sorts of patients. And like I always say, I like to meet my patients where they're at, but I'm also going to give them the evidence-based practice and or other, alternatives. But sometimes maybe that little boost of Effexor or Prestique is going to help the individual's brain chemistry feel a little bit better and get them out of bed. Start eating a little bit more so you have more energy. Therefore, you can get a little bit of exercise. And what happens when you exercise? You get natural neurotransmitters in your brain, like dopamine and other things going. So you start to feel a little bit better. So there is what do I call it? A method to this madness, if you will. Um, okay, so I'm gonna stop the video here. It is way longer than I said it was. I'm so sorry, but I just wanted to be thorough, and I hope that this helped know what is important. Again, I will continue that with the study guide. You guys are all wonderful. I wish I could just put you all in one classroom and you could all just meet, and I'm extremely lucky to have all of you. So this will be posted soon, and write down any questions you have, and we will go over them. Otherwise, we are going to be moving on to anxiety. Thank you so very much.